over the past year, we've all been getting very used to watching the daily toll of cases and deaths from COVID as they rise and fall. We see them on our television screens every evening. But I think we now know that this is only one partial picture of the pandemic. As Richard has said, from the very earliest of days, we've been hearing from people who've had COVID, but instead of making the full recovery that they would have expected, they've continued to suffer, and sometimes for months, sometimes many months. Now, we probably should have expected this, although many viral infections are self-limiting, making people feel unwell only for a few days before clearing up. We know that some cause long-term problems. Early on, we realized that this was a particularly unpleasant infection. This new coronavirus was not just causing pneumonia. In some patients, it was attacking many body systems: the heart, the blood vessels, the brain, the kidneys, and others. Now, inevitably, at the beginning, our efforts concentrated on saving the lives of the tens of thousands of people who were most severely ill. We all saw the images on our screens, particularly from Lombardy in Italy, but then progressively from elsewhere. And it took some time before we turned our attention to those who were suffering persisting problems. In fact, we owe a debt to those who were suffering from those patients, like Richard, who came together to raise awareness of this condition. And as a consequence, we now know a lot more about the condition that we call long COVID. Long COVID, the name given to it for the patients who were suffering from it. We know that about a quarter of people who've had the virus experience symptoms that continue for at least a month. And as the regional director has said, about 1 in 10 are still unwell after 12 weeks. And with the passage of time, as Richard has reminded us, many are suffering for much longer. Now, you've heard how this is a condition that can be extremely debilitating. Those suffering from it describe a varying combination of overlapping symptoms: chest pain, muscle pain, fatigue, shortness of breath, and what patients describe as brain fog, among many, many others. We are, at last, beginning to understand why people get these symptoms. They include persistence of the virus in some parts of the body that are sheltered from the immune system, such as the brain. They include direct damage to organs, such as the heart and lungs, and also to the pancreas, causing some new cases of type 1 diabetes. And then from blood clotting, the hypercoagulability associated with the virus, which can cause heart attacks and strokes. But there's a huge variety in both the pattern of symptoms and their severity. One of the most important things that we have learned about this condition is that the likelihood of getting long COVID does not seem to be associated with the severity of the initial infection. Some people with very mild symptoms at the onset still get it. But there are some people who we know are at greater risk, including women, and even though we know that they are less likely to die from COVID, and also health workers seem to be at particular risk for reasons we're not altogether sure about. Now, obviously, this is a condition that can have a huge impact on people's lives. Many people are unable to return to work or to have a social life. Many people have described how it impacts on their mental health, especially because the course of this condition is often fluctuating. And as you've heard from Richard, often they feel that just as they're getting better, either new symptoms or the old symptoms come back again. And of course, it has huge economic implications, not just for them, their families, but also for society. So we've published this new policy brief to raise awareness of the condition. We hope that it will help those who are responsible for health services to appreciate the complexity of long COVID and to give them up-to-date information about it. But of course, recognizing that the evidence is changing. And in fact, we were revising the document right up until the minute it went to press. So what needs to happen now? Well, we are calling for multidisciplinary, multi-specialty approaches to assessment and management. This is not something that can be dealt with by clinicians from any one specialty, by people with any one set of skills, by people with any one set of diagnostic tools. We need people to come together to work in teams. And that is a real challenge in many countries because of the way that health systems are organized. As Richard has said, we need to work with patients and their families to develop new care pathways. We need to listen. We need rehabilitation. We need online support tools. We need to see patients as partners in the recovery. And I mean as partners. This means working together. And that may mean new ways of thinking by both health professionals and by patients. Because unfortunately, we have seen too many times in the past when chronic conditions have seen a fragmentation into them and us, and that's not going to help anybody. We need to look at employment rights. We need to look at sick pay policies. We need to look at benefit packages for those affected. But above all, we need much more research with patients fully involved in deciding what questions to ask and how we're going to answer them. Thanks very much.